If you're a mom or know someone who is, you're likely aware of how challenging the journey of motherhood can be. From the first hopes of having a baby to the early days of pregnancy and beyond, the path can be filled with hurdles ranging from fertility issues and miscarriages to perinatal, prenatal, and postpartum depression. As a clinical psychologist, I found that many women feel lost, hopeless, and abandoned during the often challenging reproductive journey. Partners, friends, and family members often don't understand or don't know how to support maternal mental health issues. So today, I'm joined by a renowned Columbia-trained psychiatrist who will offer us a wealth of empathic, supportive information. Today, we'll focus on this listener's real-life question. My partner and I normally get along great, but I've just had my 4th miscarriage. He can't get why I'm depressed and just wants to keep trying. I bounced back after the first 3, but at my age, nearly 37, this last miscarriage took it out of me. It feels like a sign that I should give up. My OBGYN says to lower my stress and take it easy, but that's no help. Can you offer me tips? And with that question as the focus of today's episode, I'm Dr. Carla Marie Manly, and this is Imperfect Love. Please note, as this episode may contain sensitive information, listener discretion is advised. If you need special support, please see the links in the show notes. Welcome to Imperfect Love with Dr. Carla Marie Manly, psychologist, author, and relationship expert. I'm here to help unravel mysteries and misconceptions about love, relationships, and mental health issues, plus everything in between. Love is complicated, people are imperfect, and relationships surely can be tough. Together, we'll navigate this messy, imperfect space of real life. Today, I am joined by a delightful special guest, Dr. Sarah Oreck. Dr. Oreck is a Columbia-trained reproductive psychiatrist, and she's also the founder of Mavida Health. Dr. Oreck will be sharing her expertise on maternal mental health. Welcome to the podcast, Dr. Sarah. It's such a joy to have you with us today.
Thank you so much for having me. I'm delighted to be here.
So before we launch into the question of the day and maternal mental health in general, can you tell our listeners just a little bit about what makes you, you?
I love that question. So many things. I think the first thing is I'm a mother to 3, but actually had 4 pregnancies. So I had a second trimester loss, which also makes me me. I became a reproductive psychiatrist actually before even deciding that I was going to be a mother, which is interesting. But I was always committed and thought about how the transitions in women's lives that are affected by reproductive hormones, whether that's first period or perimenopause in the last period, are so incredibly impactful. So I think thinking about all of the deficits in medical school around women's health and women's health research was also a huge part of what makes me me as a clinician, and wanting to right those wrongs, wanting to kind of wrong all the medical gaslighting that happens with women's symptoms. And I'm really excited to have been able to kind of gather all of that to create something called Mavida Health, which is a platform which it really is made to democratize very specialized mental health care that was typically only available in big cities or in big academic settings and not to everyone. And so we are rapidly expanding geographically as well as in access and availability in network. And that's such a huge game changer for mental health, which sometimes is really hard to access.
So I already have two questions. You chose the name Mavida.
Yes.
Mavida.
That's also a part of who I am. So I'm a Colombian American. I'm the daughter of immigrants, which also makes me, I think, who I am. And Mavida comes from maternal and life in Spanish, mama and vida together. And yeah, that's the origin story there.
I like that. I suspected with my little bit of Spanish, in my
Yes.
background.
Yes.
I thought that might be the case. So thank you. The other piece, and it really hit me as you said it, medical gaslighting.
Oh, yeah.
That really resonates with me, and I'm sure with quite a few of our listeners. Could you explain and expand on what you mean by that?
Absolutely. So gaslighting is something that has started to, we're talking a lot about and mansplaining and all of that. But what I really see medical gaslighting is, and I actually have an anecdote in why I became a doctor in part, is because for a long time, if it wasn't explained by something that someone learned in medical school or a textbook, or it was something new, oh, well, gee, that doesn't really correlate with anything that I've seen, so this must be in your head or that doesn't exist, is often an answer people get. Instead of, oh, I may not have studied that, or, oh, we may not have the research on that, but your symptoms are valid. You are an expert in your body. Even as a physician, I'm not an expert in your body. You live your body every day. So who am I to say that those symptoms aren't happening or they don't correlate to something that I understand or know? They still exist. I can say, I'm not sure what that is. I haven't seen this. I'm not familiar with it. So it's almost like this humility that sometimes our Western medical system just doesn't have. Of if I haven't seen it and I haven't been tested on it, then it doesn't exist and you don't have it. And sort of really changing and flipping that script of like, you have something. I'm just not sure what it is yet. And I'm here to explore that with you, and how it kind of relates to actually who I am and why I became a physician is my mother went through very early perimenopause almost 30 years ago when she was in her early 40s. I was a tween then. I was like around 11, 12, 13, which of course is like this really impressionable age. And I saw my mother sort of falling apart in terms of the vasomotor symptoms, depression, brain fog, and constantly being told, you're too young to have menopause. This can't be it. People are menopausal in their 50s. You're a decade early. And so I saw firsthand her go to many physicians. And at that time, there had been a real pendulum swing in terms of hormone replacement. And so nobody wanted to give her hormone replacement, which ultimately is what ended up helping her so much. But seeing that firsthand was really incredibly impactful. And was one of the reasons I wanted to become a physician.
Thank you. Applause to you. Thank you. Because I know on a personal level, I have definitely experienced medical gaslighting. And I know in working with many clients of any gender that it is such a common issue.
Oh, such a common issue. Mm-hmm. And sadly, I think in some ways, why experts have lost their way and have been in some ways supplanted by the wellness expert that's selling you the vitamin and the thing that's not evidence-based. But we see how that kind of environment, makes it easy for people to turn to alternatives to say, well, if you can't help me, can someone help me? And sadly, now we're in a place where the evidence base, where experts are no longer trusted in the way that I think they should be. Because again, I think that lack of humility has led a lot of people to run to the alternatives that aren't necessarily safe or bring better outcomes. But I do think it has a lot to do with where we are right now in trusting science.
I really appreciate your perspective, and I wholeheartedly agree because I come from a place where in all relationships, trust is earned. And if you're experiencing something in your body and you seek help and the person is telling you, no, you are not experiencing that, and you're going home and you're saying,
What?
yes, I am, or you're in the office and you're saying, but yes, I am, and you're being told no, then you won't trust that person. And worse yet, you often end up not trusting yourself, your own body, your lived experience. So thank you. I didn't expect our conversation to take that turn, but it's beautiful and so appreciated. And I am sure our listeners are saying, oh my goodness, I or someone I know, I have experienced that. They have experienced that. So wonderful. And I imagine that in Mavida that people are getting a much different experience.
It's incredibly holistic. It's starting with patient knows themselves. And then how do we come with the humility of tell me about your symptoms, tell me what you think is going on is one of the first things our clinicians will ask. over here's what I think is happening with you. Let's create this narrative together. Let's try to figure out, are there biological reasons for you to have this? But also, what are the psychological reasons? Again, we all come with symptoms for a variety of different reasons. Perimenopausal symptoms are really interesting because sure, I have the hot flashes and the night sweats and all the list of symptoms, but the context can make them worse. We know that people that have the psychological kind of issues around aging may have more issues with that, right? Our Western sort of American culture doesn't revere older women. So becoming older is also a sign of something dreaded, versus other cultures where maybe the elderly are revered and become an even more important part of society. So it's really interesting. And that's really where we come from, holistic. We're going to try to figure out with you, and we are fully evidence-based. So we are using all the cutting edge sort of science and medications, but we're also kind of thinking about mindfulness and who you are as a person, and that your surroundings are going to be so impactful to anything that you're dealing with, whether it's postpartum, whether it's fertility struggles. And I think that's sometimes what's been missing in medicine.
Absolutely. And having the context for the symptoms, as you're saying, if somebody is struggling, whether it's with menopause or with fertility, having a sense of being supported.
Yes.
By your partner, friends, family, your medical team.
Yes.
It's a game changer.
I mean, weight loss is such an interesting one where we've done so much gaslighting to people who are facing obesity. I mean, I think about this with the documentary of The Biggest Loser and what that TV show was like, of like these, you just got to stop being lazy and just exercise and eat less. No, that's not the case at all. And in some ways, GLP-1s and these new medications have really unlocked something for people. But that's just one example of where there's so much gaslighting of like, my doctor just says I just need to eat less. And it's like, I'm doing everything I can. I've tried every single diet. I'm doing exercise every day and I'm not losing a single pound. And I'm so happy that we're starting to flip the script on so many of these issues. But we have a ways to go.
Well, thank you. And you've already given me 2 other topics to interview you about: GLP-1s and weight, and also menopause, perimenopause. So let's set those wonderful topics aside for a minute, or actually for this episode, and let's talk about one of your, favorite issues, it seems.
Yes.
Is the idea of maternal mental health. That journey from trying to conceive,
yes,
to conception, to sometimes, as you experienced, a miscarriage, and how draining that journey can be.
And I tell people it starts with even the people who are doing their egg retrievals and egg freezing. You already have that idea that you want to be a parent. To us, you've already started that fertility journey.
Absolutely. And I can think of a number of people I know who, as they get a bit older, they have started saying, I'm not sure I want to be a mom yet. Maybe I never want to be a mom, but I do want to have that egg waiting.
Yeah, exactly.
So can you tell us a little bit about some of the most common issues, looking at this individual who wrote in, almost 37, had several miscarriages, feels really exhausted. It sounds like exhausted and hopeless.
Oh, yeah.
What would you say?
Listen, I think there's like an invisible labor to fertility. There's an invisible load to it, I should say. And I think that's the first thing. Sometimes this is happening kind of in the shadows and the background. Some people aren't that vocal about, I'm trying. Some people are sort of like keeping it to themselves. And what I find so much is that people who are going through fertility, even if you're not using assisted reproductive technologies, and by that I mean IVF or those different interventions, like even if you're trying to conceive it, the old natural, the old spontaneous way at home, it can be a lot on someone to try to figure out, I've never understood what my cycle is, and now I need to understand how many days my cycle is and when I ovulate. It's the first time many women even understand how their menstrual period and their menstrual cycle works. which is fascinating to me. Our kind of education generally is pretty low in terms of what, I have many patients that are highly educated, lawyers, and if I didn't go to medical school, I don't think I would know the ins and outs. But really having to kind of learn all of this about yourself, then start to track it, you can start to see how much effort this is. And most of the effort, right, is targeted towards the female partner, especially in heterosexual relationships. You'll find kind of like a real imbalance between who's buying the ovulation test kits, who's figuring out, should I do an app? Is an app safe to do today in different states? How should I figure out, or how should I know when we should conceive? And I think that all starts to build. And if we can start a conversation early with our partners of being held in that space, hey, I need to get ovulation test kits, or I'm looking for an app that might help us conceive. Want to help me do this? And really start to partner early. I think that can be so impactful. But again, that's flipping a lot of scripts and what we in some ways take on as women automatically. So then you have this pressure of first of all, your kind of education will tell you, well, you should have been, you should get pregnant like that, right? That's what sex ed is. If a man looks at you, you're going to get pregnant. So be careful. And that's not the case at all, especially as we get into our 30s. And in late 30s, the chance of conceiving in a cycle is 10 to 15%. It's more likely you're not going to conceive that cycle. And people often don't think that. So there's these expectations of I stopped a birth control, I should just get pregnant like that. And there's almost an achievement mentality, which I've seen a lot. People that are perfectionists think, well, why isn't it just happening? It should, I'm doing everything. I just tested that I'm ovulating. Why didn't I get pregnant? And it's understanding that your odds are just not in that favor. Maybe if you were 18, the odds are slightly different, but now you're 38 or 37. And so I think that's another thing of the expectations are really high, and you do hear of friends that just get pregnant on their first try, but that is an outlier, especially in your late 30s. So trying to kind of get some understanding or science base on that can be helpful when you kind of understand the statistics are, 10 to 15% each cycle. Okay, so now you have a better understanding of, this isn't a 90% chance. This is on the lower end. So it might take me a few cycles to actually do this. And this is why that recommendation still stands that people should try to spontaneously conceive 6 months. And then if things aren't 6 months to a year, actually, 6 months is really when you're over 40, and then talk to a fertility specialist, right? That there is a year that this of trial and error before you should be talking to a fertility specialist.
And how for some people that year can be excruciatingly long, especially if they've decided now is the time.
I know. And that's where you have people kind of going to fertility specialists earlier, and sometimes that can help in terms of the education and just sort of being told, everything is working, everything's in place, let's see what happens. But I think certainly knowledge can be really helpful to understand what's happening, but to also give yourself grace. There's nothing wrong with your body necessarily. It just takes time, but it is this really interesting shift that we expect outcomes now.
Yes, we live in a world where, you touch a button and it's at your door the next day.
That's absolutely right.
It's not how babies come.
I know. And in some ways, I think that even practicing around some of those, sources of immediate gratification can be helpful. What would it be like to just have to get in your car or take a walk down to Main Street and go to the bookstore and look in a bookstore, find the book that you want to read? And I think in some ways, practicing that can be so helpful in all of these other elements where we feel a loss of control, where we feel like we can't wait that beat, we can't wait that month.
Absolutely. And I think in general, it's also really good for stress reduction when we practice being patient with ourselves, patient with life, and also patient in this journey with a partner who's trying to get pregnant, who it sounds as if she's really experiencing some grief around this.
Oh, yes. Well, we just talked about what happens when nothing is happening, right? And you're just sort of waiting and wanting. But here, this example that you presented of this case is loss after loss after loss. And I think what's really difficult here is that when you are the one, even if it's an early pregnancy and only you kind of felt any symptoms, it often isn't as real to others. I remember I had a second trimester loss. It just was more real for me than it was for for my partner, for my mother, for my friends. My partner had been there with all the ultrasounds, but there's still something different about, this experiencing. I was the one that had all the nausea. I was the one that kind of felt the pregnancy symptoms. And I think that makes it sometimes a really isolating kind of grief. And in that way, I have found that people are really under-resourced. We find that the typical kind of move is you go to your OBGYN, maybe they check the ultrasound. Oh, there's no heartbeat. Okay, well, here's some options of what you can do, whether you can, safely have the loss at home or you need a DNC. But after that, there isn't much holding. There isn't a postpartum. Right? Like I tell my patients, you've gone through the experience of being pregnant, and then that's a postpartum journey. You are now postpartum. And I think that's kind of shocking. It's a revelation of, oh, this is how impactful it can be. Your hormones have started to rise and then they plummet again. I mean, you are having that same kind of echoes of the experience that people have in postpartum, yet it's something we kind of downplay. It's not something that people are immediately referred to care for. And I can say grief looks very different for people that have losses. For some, it can be this deep loss, like, you lost a living member of your family. For other people, it's like, oh, no big deal. I'm going to try next month. And I think it's important to respect that entire range. Doesn't mean one is more valid than the other.
Thank you for that. And I'm so glad that you emphasized that if you are grieving and you're feeling a really deep loss, no matter how many weeks or months you are along, that is a real and valid sense of loss. Your grief is real. For someone who does not experience that, and they're just like, oh, okay, whatever, not meant to be, then that doesn't make them cold or non-maternal. It simply means their relationship with that issue is different.
Exactly. And I think that's so important to validate, but you also have this incongruence sometimes between partners, and that can be really hard. Oh, let's just move on. Let's try again. Well, actually, this was really significant for me, and I need to take a beat in the listener question. And that can be really hard. And this is where at Mavida Health, we do individual therapy, group therapy, but couples therapy is a huge piece of what we do, because the path to parenthood is very much changes the romantic dynamic. It changes a relationship entirely. And that starts even in the trying to conceive. And certainly when you've experienced loss, and loss that's being kind of processed differently by two partners, it can be so helpful to just get in there and talk about what these differences are. And I think I always want to go out and say, couples therapy is not just for people who are about to split up.
I agree wholeheartedly. And I wish that couples therapy was as important to people as it is to have the oil changed on their car.
Yes, that's right.
Or, get their teeth cleaned every 6 months. Because when we engage in mental health care as individuals, when we engage in it as couples, and you mentioned this early on in our discussion, how when you have a couple and they really come together, whether it's looking at apps together or figuring out what the journey looks like together, that togetherness, that sense of being connected on the same page, being partners. And I really emphasize that piece, which you're emphasizing as well in every book that I've written that has to do with relationships, and particularly my fourth book, The Joy of Imperfect Love. I talk about how important that partnership is. And if you have this healthy, strong partnership, or at least are nurturing it and actively growing it, as you go through these fluctuations,
Yes.
as you're wanting to conceive, they are maybe not, it doesn't make them less likely to arise, but it does mean that when the challenges arise, you're going through them together. You have the skills to talk. You have the skills to cope. You know how to attune to your partner. And if you don't know what they need, you know how to ask.
Yes. And that it's also okay. I know my husband did not feel the grief of our losses in the way that I did, but I think that it was also okay eventually for us to hold those two truths and be able to kind of love and respect each other, even though we different experience of this sort of traumatic event that we had as a couple. But I think that's absolutely the case. And what I'm hearing in this patient question is that there's a drifting even in their wants and needs. And, after 3 losses, it is important to start to get an evaluation to see if there's any genetic risk factors that are making this more challenging. So of course, I'm going to put that in of after 3 losses, but people sometimes preemptively do it after 1. But really, what we think of the number is after 3, we want to evaluate, is there anything else going on here that's making this pregnancy difficult?
Thank you for that. And you pointing out that after 3, and maybe this, nothing, against her OBGYN, but maybe if she's not been sent in for that kind of evaluation, or that it is time to request it, to be an advocate. And it's so hard to be your own advocate if you're suffering from sense of hopelessness or depression.
Oh, of course.
So having your partner there, or having a friend be able to go with you to advocate.
Oh, yeah.
You need.
And I think we often think about, again, this is a woman's issue. Is it her uterus? Is it her lining? And yet we are seeing more and more that actually sperm is a huge, obviously, part of the equation, but we're also seeing a lot of issues with motility and sort of sperm morphology that affects fertility rates.
Thank you, because many people aren't aware. We've been fed a diet of believing that the sperm does the job, and that in some circles, people still believe that no matter how old a man is, his sperm at 20 are as healthy as they are at 70 or 60 or 50. And that's not the case. Please tell us about this.
That's absolutely not the case. Obviously, we've seen an increase in marijuana use in our country, and we know that that affects sperm motility directly. We also, sadly, maybe have more toxin exposure, plastic exposure, which may also be impacting it. And so we're seeing kind of the use of IVF sometimes because of male factor infertility. And I think that's really important to note. So when you come and start having a conversation about what's going on, sperm checks are like one of the first things that you're going to do with a fertility doctor, which is really interesting. And again, it's just not what we're fed. It's like, oh, well, after 35, your egg quality goes down. And it's a 2-way street. Additionally, we know that men, sure, the age is a little bit higher range, like over 60, are going to have some issues with sperm quality that may lead to increase in autism spectrum disorders, for example, which has for a long time been blamed, on women over 40. Mm-hmm. But that's not the case. It's always sort of, there's more to this story, of course.
There's a lot more to the story. It's so complex, so nuanced. Now, I have another question for you. When we're looking at this listener's question, and they are feeling, it sounds almost hopeless in the sense that I picked up that it's like, it's not meant to be. Maybe there's a message here.
I know.
Do you have any tips, on that sense of, it's not right for me, as well as how a partner, friends, family, if they don't have the resources that are available in a clinic like yours, like Mavida, what are some things that they can do, to notice when somebody's really struggling, and B, some tactics they can employ, some basic tactics that they can employ to help the individual feel seen, safe, supported.
Oh, absolutely. I think so much of this can start with just telling your story. What was it like to have that loss? And for friends to just be there to hear and listen versus, oh, when I had my loss, this is what I experienced. I think too quickly we want to interject. I think we get nervous around these topics of grief as a society. And so I think we maybe want to say, oh, I've experienced this too. But what we forget is when we interject our own experience, we're not giving space for that person to tell us about their experience. Mm-hmm. And their experience may be very different from ours. I think that's something I learned because I hadn't been a mother before I was in this space, and people were always, well, how could you do this if you're not a mother? And I was like, actually, it's a huge advantage because I don't have anything to project on my patients' experiences. And it sort of allowed me to kind of hang back and listen and hear, oh, wow, this is what's occurring. And so I think friends, sure, join in. I hear you. I've been there, but really give that person space to air out what's going on. And even just being able to talk about it. I mean, for a lot of people, admitting they've had a loss is the first time that people are like, oh, I had one. Oh, grandma had 3. Oh, your aunt had 2. Like people come out of the woodworks and it's like, well, why didn't we talk about this before? Why aren't we more open that, this happens with very high frequency, that you didn't do anything wrong. You didn't drink too many margaritas at that bachelorette party the 2 weeks before you got pregnant. You're not too old, or, again, I think people have, we have it as people, we want to feel like we have so much more control than we do. So we blame ourselves for there's something wrong with my body. This must not be meant to be. But I think as you start to hear, oh, you're not alone in this, it just feels more grounding and less isolating.
Thank you for using both of those words, that you feel more grounded and less isolated. And I think both of those are so key. And I'm going back to the listener's question where he said the doctor said just to have less stress and take care of herself. That they're great words. Be less stressed, take better care of yourself.
I just want to do that, yeah.
But it might feel pretty empty. Whereas if you have a partner who really shows up and says, tell me, I don't understand. Please tell me more. Please tell me what that felt like or how your heart is doing. And when a friend or, a family member shows up, no judgment, just says, hey,
what's happening?
Yeah. Can I make you a cup of tea?
Exactly.
Let's go ahead and talk. Please share.
Right.
And it is in that space of non-judgmental empathy where that's where the grounding comes from. That's where the healing comes from. Not the, let's get over it and try again.
Right.
I get it. I get the excitement.
Or the, oh, well, at least you can get pregnant. That's a very common one. I would hold back on those. Let people kind of tell you, let the person who's experiencing the grief tell you what their kind of experience of it, what they're feeling. And even if it's different from what you may experience, I think, again, that non-judgmental holding. Oh God, I hear you. That's really, really hard. I think also with this, something that's really coming up is something I tell my patients is that for this listener, there's going to be a rearrangement of her values and her desires and her goals. And I think one of the things I ask people is not to base their values on fear and not to change what they want for themselves or a family structure that they may want because of fear of loss. And so often when we have those grieving experiences, that the fear starts to kind of drive us. I don't want to feel that again. I don't want to go there again. And so yes, you may need time, but to reorient yourself to this is what I want, and here's how I'm going to make these values aligned decisions is really hard when fear is kind of knocking at your door. But I think really important. And that's something that can be so helped by just talking those things out loud, even writing down, what are my values? What are my values in my relationship? I think those things can be helpful, and you can do that right at home.
Thank you. And I want to emphasize the piece that you just talked about, the fear, because it's so critical when you think about a woman who's had a miscarriage or several miscarriages. And the idea, the desire is there for a child, but also, as you're very clearly saying, and I want to illuminate it, that ghost of having to possibly have another loss. And so as much as you want a baby, you also have the ghost of, okay, but if I get pregnant, then I might lose it again. I might lose it. I might. And that is the anxiety and the fear coming in. And it's understandable. That fear is understandable, because then if you do have another miscarriage, bubble of hope is punctured again, and then there's more grief and loss. So what would you say, Dr. Oreck, for someone who is really looking at that specter of loss, and they, as much as they want that, they want a baby, but there's just that wall, that fear of losing again?
I know. Sometimes it just takes time, and you may not be ready now. That doesn't mean you may, and listen, there's also people change their minds, and they might think, maybe I'm okay, and my life has a great deal of meaning without children, which I also think is really important. I'm in this space, and obviously I love this transformation to motherhood, but I also think it is a perfectly valid decision to say, I have a lot of stuff going on, or I think I can make meaning in these other ways. And I always love to say, you don't have to have a child to be maternal. There are so many ways to be maternal in the world, whether it's birthing books, right? Birthing ideas, whether it's, right, being a wonderful aunt or friend. Like, there are so many ways to be maternal. I also think family structure can be all sorts of different ways. You can be a stepmother. You can have adoptive children. You can have children via surrogacy. And so I always like to think about families don't, and the idea of being a mother can look all sorts of different ways. And maybe it's different from what you initially thought. But in terms of when that specter is really there, I say take a beat, take some time. But ultimately, even having a child in this biological way or not, is opening yourself up to this grief. I talk about how there's so much loss of control that in some ways this fertility process, this pregnancy, is only practiced for the next, entire adulthood. Patients feel the same way. You give keys to a car to an adolescent. It's the same, oh my God, are they going to be responsible? Are they going to get in a car accident? So I think in some ways, it's only practice for this kind of loss of control that comes with ultimately like having a child that you do not control, who is a separate person who makes their own decisions. And in some ways, I think it reverberates to like our loss of control, even with bigger things, the political landscape, right? Like, I think it's an exercise in, how in all of our lives, we think we exercise so much more control than we probably do.
I think that is such a wonderful point to highlight, that idea of looking at it as, in so many ways, a loss of control, not needing and not needing control everywhere, and giving up our belief that we do have so much control when we actually have far less control than we often want to believe. That piece, thank you for highlighting that. I also really appreciate the part where you brought up how having a child doesn't make you maternal. There are many people who have children who don't have a strong maternal instinct at all. They have very low maternal instinct. And in the absence of a child, you can also do, or if you do have a child present, doesn't mean you can't give that maternal instinct more energy and into so many areas, as you said, into creativity, into children who really need foster.
Think of any of your preschool teachers, any kindergarten teacher, you're already seeing that, and how much of that we truly need in the world, right? Like is also important.
And not to minimize any woman who's really wanting to be a mom, not to minimize that pain, that heartache, and the importance of continuing to try as long as it's meaningful.
Yes, that's right.
Dr. Oreck, you are filled with so much kindness and empathy and wisdom. Any other tips for our listeners? I know there's so much more to cover, but
There's so much. I think grounding yourself in your today, in your present, in your surroundings, in the little joys. I think we forget how powerful nature is in helping our mental health, how powerful just getting good nutrition, enough water during the day, enough sleep can be revolutionary in how you're feeling.
You made me just think of a question. Thank you for that. And I don't want to sign off before asking you this question because you had talked about the use of marijuana and the impact on sperm. I'm not aware, what is the research on maternal use of marijuana, especially with gummies being so
popular? Oh, this is actually a big issue that we're contending with. I think, even how gummies look, they appear to be very benign. Mm-hmm. It's like a little, gummy bear that I'm taking. But the research so far, and what's hard about this is it's mostly animal models. We don't have that much research on here's patient A who used marijuana during pregnancy versus patient B who didn't. But what we see is a little bit of what we see echoed in adolescent studies, where the brain of adolescents and children is growing at such rapid rates, and marijuana is not helpful for that cognitive process. Mm-hmm. So the animal models have shown us that likely, and I can't say there's any amount of marijuana that I feel comfortable or safe with patients using during their pregnancy. And it's so hard because people easily it helps nausea for, oncology patients. Why can it help my nausea? And I think we're just at a place where we don't know enough. The data so far that's based on animals and adolescents is that we know it's not good for adolescents. We know use of marijuana, and often I say until you're 21 or older, your brain is growing, it's changing, and we see, and they have done studies that test scores on kids who are using marijuana are just significantly lower than those that aren't using it. Of course, there's other factors there. Those aren't perfect studies, but what we have doesn't make me feel comfortable with marijuana during pregnancy.
I appreciate your non-judgmental and very clear evaluation. I think it's important to highlight, and I don't steer away from controversial issues like that. So there's the research. The other piece, I know we have to go, but I wanted to mention it because it just popped into my mind that I just became aware yesterday of research on maternal health and the neonatal health during times of extreme heat.
Yes. Those studies have just been, I know, yes. I saw that too. It's people, this is a whole other topic. Climate change is a mental health issue. It is a health issue.
Yes.
And I think this is one example where we're going to start to see that.
And I was stunned. It makes perfect sense. And they were really talking about it's not temperature itself. It's the fact that if you're in an area, for example, that's used to 80s and there are really high heat, it's going to affect the individual's health, particularly, mom and baby. And if you're in an area that's routinely 100 and it's 105, that's not going to be bothersome because the person is accustomed to that. So all of these little things that we want our listeners, if they're struggling with fertility and issues, to be aware, a doc like you is going to be so helpful because you look at the whole individual as well as current research. And I'm so grateful. So thank you for that.
Dr. Carla.
And listeners, where can they find you, Dr. Oreck?
So I know how important the care I give is. And so basically I've multiplied myself and I've created Mavida Health, and you can find us there, mavidahealth.com. We are currently live with clinical services in California, New York, New Jersey, and Texas with most major commercial insurance. And we have an app which is actually available for free for everyone in the US. And that is, again, you just have to sign up mavidahealth.com and you can have access to all of our meditations, teachings, all on, the path to parenthood, perimenopause. You have access to all of that information for free. We're also on Instagram at Mavida Health, and my personal Instagram is at Sarah Oreck MD with a lot of tips and tricks on your mental health.
You're wonderful. And I thank you so much for all of that information, listeners. It will be in the show notes so that you can easily find Dr. Sarah. Her spelling on her name is Sarah. Last name is Oreck. So that's Dr. Sarah Oreck. And Mavida is Mavida. Again, links will be in the show notes. Thanks again, Dr. Oreck. I so appreciate your time, information, your energy. Just
Thank
lovely.
you so much. I appreciate it.
And to our listeners, I thank you for going on this journey with us today. It's always a joy to share time and wonderful information with you. And this is Imperfect Love. Thanks so much for sharing your time with me today. Remember, you have the power to transform your life and love fearlessly, if imperfectly, and it's my privilege to help you along the way. You can find more life-changing content, including my books and other podcast episodes, at drcarlamanly.com. Feel free to submit your own confidential questions through my website. I'll do my very best to include your issue on a future episode. If you found this podcast helpful, please subscribe and leave a review. Until we connect again, this is Dr. Carla Marie Manly wishing you oceans of blessings and love. Please note, this podcast is psychoeducational in nature and is not intended to replace formal mental health support. Please contact your healthcare provider or emergency hotline if you need psychiatric care. And, as always, please take good care of your amazing, wonderful self.